welcome to the Lurie Cancer Center's virtual town hall meeting focused on protecting people with cancer from COVID-19. My name is Alex Zafrovsky. I'm the Chief Administrative Officer of the Lurie Cancer Center, and I'll be serving as an MC and a moderator of tonight's discussion. I'm joined by Dr. Leonidas Platanias, who is the Director of our Lurie Cancer Center, and Dr. Michael Ison, who's the Medical Director of Transplant and Immunocompromised Host Infectious Diseases at Northwestern Medicine. Drs. Platanias and Ison will be discussing the current status of the COVID-19 pandemic, Omicron and other variants, and latest clinical data on vaccines, boosters, breakthrough infections, and emerging treatment options. We have an enthusiastic response to this town hall. As of right now, we have over 300 participants. Half of those have never participated in any of our events. 26% are cancer patients in active treatment, and 40% are cancer survivors, and the remainder are family and friends. Most of them from around this area, but we also have 17 other states represented, as well as Philippines and Greece. So thank you all who have submitted questions in advance. We have lots of questions to get through, and you'll still be able to submit questions through a Q&A feed. Your microphones and cameras will remain off just to minimize the distractions. We will also record this webinar and post it on our website for future reference, as well as all of you register will receive a link. So feel free to share that with your family and friends. So as we get in, I will turn it over to Dr. Platanias to kick us off.
Good evening. Thank you everyone for being here today. We hope that this will be an informative session, and we're gonna go through all your questions, and we're gonna try to do it within the time we have. And we're gonna start with Mike Ison, who is gonna give us an update on what's going on with COVID right now and talk a little bit about Omicron. And then we're gonna go back to Alex and start taking questions. So Mike, go ahead. Yeah.
Great. Well, thank you very much. And so what I'll try to do is give just a very brief over the next couple of minutes update on what we know about Omicron and ways to keep people safe, because I think this will also answer a lot of the questions people may have. So when we talk about Omicron, this is the same SARS-CoV that we've seen before, but the spike protein, the main protein that the virus has that leads to infection and is how we develop protection against vaccine, has a number of mutations that prevent the antibodies that you have from prior infection or vaccine to bind less efficiently. And this is why we see higher breakthrough rates of infection, particularly in patients that have been unvaccinated, as well as those patients, unfortunately, that have been vaccinated and boosted. While the benefit is greatest in people that are boosted, where the vaccine efficacy is about 75% preventing Omicron, it's still a little bit less than what we were seeing in boosted individuals against Delta. We've seen that there's higher rates of transmission of Omicron compared to Delta. This is true in households. So if you've got someone sick in the household, others in the household are much more likely to become infected. The vaccine efficacy really does need that third booster dose to really improve the efficacy against the virus. Once you do get infected, the incubation period is reduced. And unfortunately, there are breakthrough infections even among those healthy individuals. I think the key take home, though, is that those breakthrough infections tend to be much milder, and the vaccine provides very significant reduction in the risk of hospitalization and severe disease. So looking at the impact of this pretty significant Omicron wave, in red is our hospitalization rates, and they're at a level higher than we've seen prior in the pandemic. But thankfully, I'm going to point to the bits of good news where it looks like hospitalizations and, more importantly, the test positive rates are starting to come down. And so I think we're probably at the top, and we'll hopefully start seeing cases and hospitalizations come down very soon. Looking at the dashboard for the city, they're similarly seeing declines in test positivity as well as case rates. And there is significant variability in parts of the country that are being infected or being affected. We had much of the South was at relatively low rates, but ever since the holiday, really rates have gone up significantly in most parts of the United States. I think I put this slide in just to remind people that there are some populations that do remain, even with vaccination, at higher risk of hospitalization. The older you are, particularly if you're over 70 years of age, irrespective of your underlying medical condition, even with a vaccine, you are at slightly higher risk than younger individuals. And this is just important so that you do the extra steps to keep yourself protected. I think one of the common questions, because the guidance has changed a lot, is what is recommended in terms of vaccines. For non-immunocompromised patients, it's recommended to get either the Pfizer, BioNTech, or Moderna vaccine as 2 initial doses about a month apart, and then to receive a booster dose 5 months after the initial round of vaccines. Everyone, irrespective of their immune status, who have previously gotten a dose of the Johnson & Johnson vaccine, needs a booster dose at least 2 months after their first dose. You can get any vaccine, and you get a better boost if you get one of the mRNA vaccines. And I think this is my chance to plug. If you haven't gotten your booster, now is the time. Don't wait. This is the time, because you need that added protection from the booster to protect you against Omicron. Among immunocompromised patients, there is recommendation to get a 3rd dose 1 month after the first 2 doses of the Pfizer and Moderna, and that all individuals should get an additional booster dose 5 months after their 3rd dose of Pfizer or Moderna, or 5 months after the Johnson & Johnson vaccine. And while the vaccines are incredibly effective, we do need to remember you need additional layers of protection to keep you safe, particularly against Omicron. You need to add things that we were doing in the past. You need to wear that mask. If people are sick, you need to quarantine and isolate. You need to optimize ventilation, which is harder now that we're in the winter season. Avoid crowds as much as possible, particularly crowds where a large portion of the population is unmasked for more than 15 minutes, like bars, restaurants. Be careful with cough, wash your hands diligently, and together, this kind of Swiss cheese of protection will enhance the protection for you against the Omicron. So with that, please wear your mask, please get your booster, and I think we can move to questions.
Okay, perfect. So let's jump right in. Chris, maybe we start with you with a question that was just received. This particular person has already been boosted, but just recently tested positive. Would you recommend a 4th dose?
So with the booster, if you are not immunocompromised, a 4th dose is not recommended by the US government or the CDC at this time point. Only immunocompromised patients, which include patients that are actively getting chemotherapy, are authorized to get a 4th dose.
Look, Platanias, this is a 2-part question, but related. Should people wear more than 2 layers of masks to protect against Omicron? And how can people tell the difference in which masks are good and which ones are not good?
Yeah, that's an important question. It's particularly important for populations that are more at risk from this infection. So it's not an issue of how many layers you wear, it's the quality of masks. And we know now that N95 masks offer the highest protection, and so are KN95, the related respirators, as we call them. And at the beginning of the pandemic, it was difficult to find these masks. Now it's very easy. There are many places you can get them. It will be important, obviously, to be good quality. Someone asked earlier on chat, where can they find good N95 masks. There is a site called Project N95. That's a site that has been I think has credibility, and they have high quality masks. But there are also many other commercial sites that you can get them, and the price has come down significantly. So I think for Omicron, people should try to use these masks. Surgical masks are better than cloth masks. Cloth masks are the worst in terms of protection of the person who wears them. I will not recommend anyone wearing cloth masks anymore. I would strongly recommend that they wear K95 and above, and surgical masks are better. So,
thank you. Dr. Ison, a clarification on the previous question. If someone is immunocompromised and has already received 3 primary doses of Moderna, should the 4th dose be a full dose or a true booster, meaning half dose?
It's counted as a booster, and you won't be able to ask for a full dose versus a half dose. It's automatically categorized as a booster dose, so you'll get the reduced dose. And I'll just say, I think a lot of people are very nervous about that. I think that there's some emerging data that suggests that kind of lower dose may actually be almost equivalent to the full dose. You get slightly less reactogenicity with similar antibody responses. And so, when they approved these vaccines, we didn't have time to do a lot of dose assessment. They went with the highest dose that they had. And now we have some more data. And so I wouldn't be worried about getting that lower dose.
Okay. Dr. Platanias, we keep hearing that Omicron is milder than Delta, et cetera. Do we know, based on data, that this generalization is applicable to the immunocompromised and immunosuppressed?
that's a good question, and I'm going to ask Mike to give his opinion. My opinion is that when you are immunocompromised, you are at risk, and you are more at risk from Omicron than people who are not immunocompromised. So it is, part of the milder version, the fact that we see Omicron being less, less aggressive disease has also to do with that, with people who are vaccinated. If you are vaccinated, is a much milder course with Omicron. But if you look in the ICUs right now and the people admitted in the hospitals, 90% of them are unvaccinated. So I think both people who are not vaccinated and immunocompromised who are vaccinated are at much higher risk from Omicron, and we should do everything we can to minimize their exposure to this agent.
Yeah, and I think just to you said it right. I mean, this is immunocompromised patients are definitely at increased risk compared to a non-immunocompromised patient, but really the risk is in the unvaccinated, and the really scary group are the ones that are immunocompromised and unvaccinated. I think a lot of focus has been on antibodies, and some people may have been frustrated that not all patients developed antibodies, but many patients, even if they don't develop those protective antibodies, develop the cellular responses that help protect you against severe disease. And we are seeing that while there are some immunocompromised patients being admitted, the majority are having milder illnesses, not requiring the ICU, not getting so sick that they are likely to die from the infection. They do need some oxygen support. They do need some therapies that we can give only in the hospital, but they are generally recovering. And so really, I think this highlights to something I know you're incredibly passionate about, is getting everyone vaccinated. And so this is not just important for you, but everyone around you, because it's the people around you. If they get infected, they can easily infect you as well.
Yeah, Mike, if I may add here, unfortunately, we still have a significant group of people who are not vaccinated. And this is the outcome of misinformation. In these days, anybody can go on the internet and write whatever they want. The fact is that these vaccines are very safe and very effective. And being vaccinated is very important to protect yourselves and others. So we will strongly encourage everyone to get vaccinated and not be afraid. you should discuss it with your doctor. Make sure all your conditions have been discussed with your doctor, but this is something that really saves lives these days. And I want to emphasize also the issue of the booster. There is a large group of people who have had all the vaccines, but have not gotten the booster first. And I want to remind everyone, and Mike already did, that it is important to get the booster, especially for the Omicron variant. There are data that getting the booster adds up and helps fight the Omicron.
Thank you. Dr. Ison, Evershell, EVUSHELD from AstraZeneca, like a three-parter. I try to summarize. Can you talk a bit more? And then there's a specific question about a friend who had a kidney pancreas transplant and cannot be vaccinated. Is it effective for transplant? When it would be available? Maybe a quick primer on the vaccine.
Yeah, so I think there's a lot of questions about Evershell. So what we know, and a lot of people have heard about the monoclonal antibodies that have been used for treatment. These antibodies basically are the same types of antibodies that you developed the vaccine. They've just been produced in a large concentration so that can be given to you passively so that those antibodies can stay in your blood to either speed your recovery in the case of the therapies that we've been using in the past, or in the case of Evershell, these are in your body for a very long time, at least 6 months, probably a lot longer than that. And they help protect you from becoming infected in the first place. The preliminary data, which was with older variants, predominantly the Alpha and Delta variant, showed that these therapies were incredibly effective, 80 to 90% effective in preventing primary infection in patients. And so because of that, there's a lot of enthusiasm for being able to get this therapy out to those patients, particularly our immunocompromised patients, that are either unable or unlikely to respond to the initial vaccine. Unfortunately, the available doses for this fall very short of the number of patients that we have. We have set up a tiering system, prioritizing patients that aren't able to respond to vaccine because of some of the therapies that they're getting. And that's a relatively large number of patients throughout the Northwestern system. And the number of doses that are available for the entire state is only about 600 doses. And that's less than the number of patients that would be eligible for that. So we will be rolling it out in the near future. It will be prioritized to certain individuals. The way that it'll work is you do not need to call your doctor to get access to this. We will be working our way through a prioritization system, and you'll get an invitation to come in for the treatment once the dose is available for patients like yourself.
Thank you. Thank you. Dr. Platanias, a mask question. The two, I'm trying to put them together. So if you have a N95 or KN95, how often should you change them out and replace them with a new mask? And do you also know if a KF94 is just as good as N95?
Yeah, let me start with the second part. The KF94 are very good masks. They are pretty similar to KN95s, and they're from Korea and they're used in Europe a lot. So they are reliable. They're good masks. I would recommend that. The question of how long we should be wearing the N95 or KN95, I think it will depend. First of all, you don't want the mask to get wet or damaged or anything. So, but I will not recommend wearing it more than a day, more than a few hours, several hours. It can be reused, and I will have Mike give his opinion here. But what I do, and my advice is, I wear it for several hours within a day. If it gets damaged or something happens, then I replace it. And we have enough masks right now that we can do that. In the past, people were using them for days and so on. I don't think that's a good idea. Mike, what do you think?
So, these masks are probably relatively safe to reuse. I think the big things that I would do is some simple things. If it's starting to smell or is getting scratchy or uncomfortable, clearly that's the time to switch them out. I think the most important thing is the seal. The way that these masks work is by sealing around the skin, and as long as you have that nice tight seal, which can loosen as you wear the mask over time, the mask is still doing what it needs to. And then, of course, if there's any tear or break or areas that look like they're thinning, that's the time to get a new mask. And again, much like a lot of things during the pandemic, everyone's now focused on getting these masks, and so there may be a short-term shortage of these, and so you may have to reuse them and use them slightly longer than you may want. Over time, these are going to become much more easy to buy at the store and online.
And one thing that actually can prolong the life of a KN95 or N95 is putting a surgical mask on top. Double masking with an N95 with a surgical mask on top, then I think that helps a little bit. But again, I think there is availability now, and what Mike suggested about the damage the mask is critical.
Thank you. Dr. Ison, here's a question about timing. So there's been talk about Omicron vaccine coming out in March. Should someone who is immunocompromised wait to get that vaccine instead of a regular booster? Somewhat related to someone has not been boosted, but they just got COVID and they're thinking about waiting till March because of the Omicron specific vaccine. So any thoughts on those things?
So my answer is quite simple. Do not wait. The Omicron is there. The risk is now. Now is the time to get the booster. We hope that the Omicron booster will be very effective, but we don't know. I think a lot of us were very disappointed when the pediatric trial for patients under 5 failed to show benefit, and we're still learning. That's why the studies are ongoing, and God forbid it's less effective than we think that it is, and you have waited, exposing yourself to the risk for now. The need is now for the protection, and the current booster is all that is available. So I would not wait at all. In terms of patients that have had infection, this is probably the #1 question that I get. When can I get the a booster or additional vaccine if I've had COVID? As soon as you have recovered clinically from the infection, so you're feeling back to normal, and that you've cleared the quarantine period, which may be a little bit longer for patients that are immunocompromised, you can go and get the booster dose. The one caveat to this is if you've received one of the monoclonal antibodies for the treatment of your COVID, then you need to wait an additional 90 days after you got the monoclonal antibody before you get any booster, because that monoclonal antibody could bind to the vaccine and make it less effective.
Thank you. Dr. Platanias, a 3-parter, all related. So if I am receiving chemotherapy, am I considered immunocompromised? And if I am receiving chemotherapy and I get COVID, what may I expect? Simply put, what should a cancer patient do when diagnosed with COVID besides calling their oncologist?
So not all chemotherapy have the same effect. So, and not all cancers cause the same degree of immune compromise. So it is, yeah, I understand that what else do you do beyond calling your oncologist, but talking with your doctor is critical, because your doctor also will contact maybe an infectious disease specialist like Dr. Ison, get input on your case. So every case is different. There are some patients with some types of cancer that are much more vulnerable than other ones. Transplants, bone marrow transplants, lymphoma patients getting treatment that includes steroids, lung cancer patients are at higher risk. But I think each case is individual and you need to speak to your doctor. And I will ask Mike to see what he thinks as an ID specialist here.
Yeah, I think I would start with talking with your oncologist as the first point, and then if they feel that they need help in figuring things out. And part of the reason why I think that talking to your doctor is really important is, as you pointed out, there's differential risk of poor response by different chemotherapies. There may be also the need to give the dose at certain intervals between some of those therapies. And a conversation with your oncologist can really help determine when is the ideal time for you to get the vaccine. We're always available to you or the oncologist to help figure this out. But for most of the treatments, there's some guidelines that are available to kind of help us understand when to give that dose relative to the chemotherapy.
And we have to keep in mind always that cancer is a problem and we're trying to cure cancer. So it is very important to avoid problems from COVID. And that's why talking to the doctors can smoothen out the communication and get things going.
Definitely.
Okay. So I'm trying to combine some of these, but maybe we'll just go one at a time. Maybe a lightning round here real quick. So a person is in a situation where unfortunately they have to inhale some smoke that's infiltrating their home in terms of their neighbor is smoking. They're wondering if they're breathing that smoke, are they also breathing in their COVID?
So that's I think a hard thing to answer without seeing exactly. A lot of times you can smell it through the walls. I will say, I've had that in my old apartment where I could tell when the neighbor next door was smoking marijuana. But that's seeping through the walls. The virus, just like a mask, needs to be kind of directly through the air to you. And if it's filtering through the walls, it's unlikely to get to you. If there's an actual hole in the wall or there's a gap, presumably they could. But again, it also would depend on what the airflow in the space, if you've got the air conditioning or heat running and there's high filtration through the air, that's less of a concern.
Okay. Mask question, Dr. Platanias. I have a 3-layer cloth mask with a filter. Can I still wear it and be considered effective?
So if there are these filters that are the same filters that are in K95s, and I think these cloth masks, when you put the filter there, they are much better than regular cloth masks. But I still don't think they are the same quality as a good N95 or a K95 in terms of the sealing that Dr. Ison was recommending. So these masks are definitely better than regular cloth masks, but I will still go with the best mask that we have around. So,
Dr. Ison, a 2-parter related. Recently diagnosed with a health condition that's considered to be autoimmune and can trigger autoimmune disorders. Does that put me at increased risk? And can you please remind me again when I can get a 4th booster? How many months from the previous?
Yeah, so the autoimmune condition probably doesn't in and of itself increase your risk, but depending on what they're treating you for, that may increase your risk. And with regard to if you're immunocompromised, the 4th dose is 5 months after the 3rd dose.
And who is administering the 4th doses?
So you can go to a lot of places to get the 4th dose. You can go to your local Walgreens or CVS or other pharmacy that's close by. Nearly all require you to make an appointment online. And the questioning really does kind of lead you through and ask you if you're immunocompromised. If you do, it asks when the date of your last vaccine is and won't let you schedule the appointment if you're within that 5-month period. There are opportunities through Northwestern to get vaccinated at certain locations, and I would point you to the Northwestern Medicine homepage to find those locations on campus. I will say it's probably a lot easier for most people to schedule and go into their local pharmacy to get them. And then if you have challenges with mobility and live in the city of Chicago, you can go to the City of Chicago COVID webpage, and they do have options for people that are homebound to get the vaccine administered in the home.
Thank you. Dr. Platanias, a cancer-specific question here. Somebody is currently receiving chemotherapy, they're fully vaccinated and boosted, and the question is, if they happen to get COVID, will there be any restrictions on what therapies they can receive?
Well, it has to be, if they get COVID and they need therapies, if they have a significant disease, the drugs that they get, the chemotherapy they get, has to be looked carefully together with if they get any of the new treatments for COVID. So someone has to review that and make the decision, but it depends from drug to drug. That's why we have pharmacists working with us and various other people. And Mike, I would like to get your input on that as well. If you...
Sorry, I missed the
The
question.
question was if someone getting chemotherapy gets COVID.
Right.
And what I said is that we'll have to look, depending on what COVID medication may be used, we have to look at the interactions of the drugs and all that stuff. So it has to be discussed with the doctor, and they can check with pharmacists and all these things. But the good news is that if you are vaccinated and boosted, the chance of this being a severe disease is very, very low. So Mike,
Yeah, I think, and especially I think this may be getting at, one of the other questions that started to pop up is some of the oral therapies for treatment of COVID. You definitely need to, and even if your primary care doctor or another doctor is prescribing them, I would, before starting them, talk with your oncologist, because there may be not just the chemotherapy agents that you're taking, but some of the other medications that are helping protect against infections and the like that may interact with some of those therapies. And then if the question was, how would it impact? I was thinking it was about the chemotherapies, and how that would affect that. Again, that'll be a conversation with your doctor, because as you pointed out, it's a balance. We have to make sure that we aren't making things worse with the chemotherapy. But if you've recovered well enough and have a low enough amount of virus and it's felt to be safe to create.
I mean, this is something we do all the time when we give chemotherapies. Even when we give other drugs to protect from other infections, we always double. Sometimes we need to adjust the chemotherapy. So it is important to talk to your doctor and, cross-check that.
Thank you. Dr. Ison, the patient is asking that they heard there's a shortage of monoclonal antibodies, and like you just mentioned, the new oral meds from Merck and Pfizer. What's the availability at Northwestern for cancer patients, and how will they be prioritized, if at all, given the patients with COVID?
Yeah. So I think, unfortunately, for all of the therapies for COVID-19 outpatient, they're in relatively limited supply. And this is in part because we were relying heavily on two sets of monoclonals, BAM-EDI and Regencov, two different combination therapies for the treatment of COVID-19, but they do not have activity against Omicron. And so we've switched to a different monoclonal antibody called sotrovimab. This is the US government had less of this in stock. They're increasing capacity of this and distributing more as time goes by, but it's still much shorter. The priority that we have at Northwestern puts immunocompromised patients at the top of the tier for giving them the priority access to these therapies. Similarly, the oral medications like Paxlovid and Molnupiravir also are in relatively low numbers being given to the state, and then those are distributed out. The pills for now are not going to be available at Northwestern, although the Northwestern doctors can order them. They're being predominantly sent to Walgreens and Walmarts currently, with more pharmacies being added over time. Even though they're at those pharmacies, not every Walgreens and not every Walmart will have them. In fact, throughout the entire state of Illinois, only about 26 Walgreens will have these, and only about 18 Walmarts throughout the state will have these therapies. There are some public websites. Your doctor will be able to guide you to where those therapies are, but they may not be something very close to where you live, and you may have to go someplace else to get those.
Thank you. Dr. Platanias, can cancer patients be tested for the effectiveness of their vaccine?
Well, there is, one can measure antibodies, but it's not a very reliable way, because the effect of the vaccine is not just the antibodies, it's also the T cells, and we don't have assays for that. So one can measure antibodies, and but it's not, it's not a very reliable way. Mike, what do you think of that?
Yeah, I do worry a lot that people put too much weight on the antibodies. Even if your antibody is negative, you may have developed those cellular responses that help protect against severe infection. You are at risk of getting infected, but your risk of getting severe infection is slightly reduced. The other thing is, just because it's positive, we don't have a specific threshold that shows that you have enough vaccine response to protect you from Omicron, and it's just a snapshot from today. Even if you're just barely above that level today, a month from now, it may be below that. And I worry that a positive or a negative result may give slightly misleading confidence or fear to patients, and it's not something that we recommend checking for our patients.
So that's exactly my concern also. And the question is, should patients be doing those at all, checking the antibodies? I don't think so. What do you think? I mean,
yeah, like I said, I worry that the results will sway people in directions that may be dangerous. And the one that's even where I am more worried is where they find that they have detectable antibodies and think that they're protected,
right,
when in fact those levels may be too low. And particularly since we know the antibody levels wane over time, even if they're protective today, it doesn't mean a week from now you're not protected.
So the important thing is get your vaccine, get the booster, and you have done what you're supposed to do with that. So.
Okay, Dr. Ison, two-part question. When does the protection of a booster start to decline, and what can you share about ivermectin?
Yeah, so the first part is that the booster efficacy does decline against Omicron the further out you get from the boost. So within the first couple of weeks after you get the booster, the protection is about 75% in preventing infection compared to unvaccinated individuals. Once you get out closer to that 3-month mark, that drops to about 40% protection against Omicron. But that's just talking about protection against disease. We've seen now several articles that have come out that have clearly shown getting vaccinated, and particularly the additional benefit of boosting, decreases the risk of hospitalization, and the booster further decreases the risk of hospitalization, particularly in high-risk individuals. The simple answer about ivermectin is that I don't believe it works. We just came out with a statement with Northwestern that that's not a therapy that we recommend for patients to receive here at Northwestern.
Thank you. Dr. Platanias, this is about immunocompromised. I think there's questions about what's considered immunocompromised. I can maybe read you this example, but more broadly, who is immunocompromised? So does lymphocytopenia of absolute value of 230 make a person more susceptible to COVID-19? Would that qualify as immunocompromised? This is due to the chemo and pelvic radiation due to endometrial cancer. And then the other question that's related, how do you determine if immunocompromised are unable to respond to the vaccine? So can you speak a bit about how do you know if you're immunocompromised?
So there are some drugs that we use in oncology that compromise the immune system, usually transiently. There are steroids, there are various other drugs immunosuppressive drugs. Many of them are used for transplants, either solid organ transplants outside of oncology or for bone marrow transplants. So all these things can cause immunosuppression. Lymphocytopenia, when your lymphocyte count is low from treatments or whatever other reason, is part of that too. So, and there are some chemotherapies, when radiation therapy is another example during that period that can have an immunosuppressive effect. And some of the chemotherapies can do that. So in general, if someone gets chemotherapy, is more vulnerable than patients who don't get chemotherapy. But it also depends. There are some drugs that are especially immunosuppressive. So I will say cancer patients who had cancer in the past and have recovered and they are cured, they are not usually immunocompromised, although there may be exceptions to that. But patients who get active treatment or who have some types of blood cancers or go through transplants and all that stuff are more vulnerable. So again, talking to your oncologist is important because there is a wide spectrum of, there are degrees of immune suppression that may matter in this case. So, and what was the second part?
It's along the same lines of how do I know that I'm considered immunocompromised, therefore eligible for, some of these boosters?
So again, your oncologist knows that, and they deal with that all the time.
Yeah, but in general, I think I will say what my cousin was being treated for a blood condition, getting a lot of immunosuppression, and he didn't think he was immunosuppressed until we chatted. So if there's any questions, reach out. If you're receiving things that are steroids, chemotherapy, things that may weaken your immune system, like cyclosporin or tacrolimus and the like, those would make you immunocompromised. But definitely, if you have any question, or if you think you may be, definitely talk to your doctor because you definitely want to get the extra protection if you are immunocompromised.
And an especially vulnerable population is patients who had solid organ transplants because they stay usually, many of them, on immunosuppression for a long time. So that's something else to keep in mind. So,
Dr. Ison, here's a question about long COVID. This person has just been diagnosed with Omicron after being able to avoid it for all these 2 years, fully waxed, boosted, wears a mask all the time. But the question is long COVID as likely with Omicron? Do we know any of these things in terms of recovery?
Yeah, this is a great question. Another one that I get a lot. So I think the one thing that I think we just need to keep in mind is long COVID is someone that has persistent symptoms 30 or more days after recovering from infection. And so our first case in Illinois was at the very beginning of December. So we're just barely at that threshold. So we don't have a lot of data yet. And we know that Omicron is different, so we will definitely be collecting that information. What we do know from the prior variants, and I expect this very much to be the case with Omicron, is that if you're vaccinated, there's a huge 90+% reduction in developing long COVID symptoms among vaccinated individuals. So again, the benefit of the vaccine goes beyond preventing infection and preventing hospitalization, but preventing some of those challenging longer duration symptoms.
Thank you. Dr. Platanias, this is a very detailed one. I'm trying to get more of the specifics, but it's very difficult to address the specifics, as you both mentioned, probably easier to talk to the physician. But here's one that maybe we can address. I was diagnosed with stage 4 cancer in 2014 and completed immunotherapy 4 years ago and haven't had any treatment since. I've been careful, working from home, masking, fully vaccinated, boosted. With Omicron now, should I be following guidelines for immunocompromised? And how would I get if I'm immunocompromised? I was never contacted by Northwestern until the vaccine was public for everybody.
So the patient finished the treatment 4 years ago, you said? And
Yes.
And again, it also depends what was the underlying disease and so on. But clearly, it's a much better situation. For 4 years, you haven't, and it was immunotherapy, right? It was
Yeah. So the question is, I think, like, should I get the 4th dose? Like, will they let me?
I don't think so, but the information is not sufficient to make that call here. But my feeling is that probably not. And but I will still be very careful. You know, all of us will be very careful, and especially if you got any treatment in the past, you never know. So you have to err on the side of caution. Be very careful with Omicron. Wear good masks. Get boosted. But the fact that you are 4 years from your last therapy, that's a good sign for the cancer also is, so keep it up.
So follow up to that, Dr. Platanias, a similar situation, but more recent. Chemo was completed in April for breast cancer of last year, and no other treatment. Would they still be immunocompromised? They had their first dose 2 weeks after the booster. I've had first dose of Pfizer 2 weeks after, and my booster last month. Okay, so they're boosted. The question is, do we know if vaccines have any additional cancer risks, for especially considering she had breast cancer?
Yeah, no, I don't think there is any evidence at all. And that's again part of the misinformation that we read in the, people go and say whatever they want, but there is zero evidence that the vaccines cause any cancer risk. And we've been using this vaccine, has been tried in so many people over this period. So absolutely not. I will not be worried at all about any pro-cancerous effect of the vaccine. And the fact that this patient got the vaccination and the booster, I think they're good, well protected right now. So.
Dr. Ison, maybe 2 quick ones, at least appear quick to me, I guess. I don't have a spleen, but been taking penicillin for over 20 years. Am I considered immunocompromised?
So patients that are asplenic are considered immunocompromised and tend to respond less well to vaccines. So you should follow the immunocompromised pathway to get additional doses.
Okay, and the second one is, should one get a J&J vaccine for the 4th shot if they're immunocompromised? I had Pfizer for the first 3.
No. So I can say it probably doesn't matter which of the mRNA vaccines you get. The efficacy of J&J is much less. And really the mRNA vaccines are the way to go. There's not a huge amount of benefit in even switching between Pfizer and Moderna. And so if you've gotten 3 of one, I would get the 4th of the same.
I think, this maybe whoever asked that question, there was a small study that was published recently that was showing that either J&J or AstraZeneca, when you gave it after mRNA vaccines, had significant activity. But again, that was a small study. The experience right now is mainly with mRNA vaccines. So I will just stick with what we know well, and that's to get another mRNA vaccine shot. So.
So Platanias, follow up on the Project 95 promotion we said earlier. I'm just kidding. Does it need to be a respirator mask? There's a flat fold N95. Would that be acceptable?
Absolutely.
Comments.
Yeah, absolutely. I mean, again, this site is a site that, I think these things have been checked. And there are other sites. It's not the only site. Just someone asked for a site that. But the flat N95s, they're great. In fact, in the hospital, we use a variety like that, flat N95s that are very protective. So absolutely. Perfect.
Thank you. Dr. Ison, do you want to briefly just discuss the Pfizer treatment option that's coming out, the Paxlovid?
Yeah. So there's going to be two pills. The one that I think most people are going to be interested in is the Paxlovid, which is a combination of two different antiviral medications. The first is the main active drug, and that blocks one of the important proteins that allows the virus to replicate. Unfortunately, the body clears that drug out of your system very, very quickly. And that's why the second drug, ritonavir, is given in combination with that first pill. And that blocks the breakdown of the active drug and allows it to stay in your body a lot longer. The downside, though, is that ritonavir blocks the breakdown of a lot of different medications. Even common things like cholesterol medicines can be affected by this. Common antifungal medications can be impacted, and a lot of the immunosuppressive medications, including some chemotherapy agents. Because of that, it's really important if you're actively receiving any medication that you review those medications with your doctor before starting the Paxlovid. The flip side, though, is you don't want to wait too long. So as soon as someone tells you they're going to prescribe this, that's the time to get on the phone and see if that's a safe drug for you to take, because these therapies are best the quicker they're started after you develop symptoms. And in fact, you can only receive these therapies within the first 5 days after you're become symptomatic or have a positive test for COVID-19. The second, and then in terms of efficacy, the Paxlovid has been shown to be incredibly effective. It reduces the risk of requiring hospitalization among high-risk patients, including immunocompromised patients, by about 80 to 90-fold. So it really does reduce the risk pretty significantly. It also speeds the recovery and clears the virus out of the system. The problem, as I mentioned, is there's very few doses. The whole state of Illinois has 2,000 doses of Paxlovid every 2 weeks. And especially now when we have literally tens of thousands of people testing positive, those supplies will be depleted very quickly. The second medication, molnupiravir, does not have the drug interaction concerns of that Paxlovid does, but is far less effective against preventing hospitalization, only about 30% effective in preventing hospitalizations. And so this won't be, in general, our first choice for patients, but because we've got shortages of the monoclonal and the Paxlovid, if that's the only option, it's still a great option for you because it's still reducing your risk. Though there are some patients that it's not appropriate for. It cannot be used in patients that are pregnant or expecting to get pregnant in the near future, and people that are taking this medication and their partners will need to use barrier forms of contraception for 3 months after they take the medication.
Thank you so much. Dr. Platanias, are there any long-term risks from repeatedly activating the immune system via the 4 vaccinations?
So there is no, so far with the 4 vaccinations, I don't think there are any long-term risks that we know. And I will strongly recommend patients who have this indication to continue for that. There are theoretical things, there are different theories. If you keep doing that, what will happen and so on. But the fact is that right now, we don't have any evidence for anything like that. And we know for sure that the vaccines are very effective and save lives. So I will not, this is something being studied very carefully, all these things by the CDC, by the FDA, before any further, doses are recommended. But for what we have right now, I don't think there is any risk, and I would strongly recommend to follow up whatever is recommended.
Thank you. We've got a few more minutes here. Do we have any ideas or emerging theories on why, some younger patients that appear healthy can still get very ill and die from COVID, as opposed to what we used to see?
Yeah, so we used to see very young people getting COVID and getting very sick as well. Oftentimes, they're not as healthy as they view themselves. I think that, one thing that people miss is some of the leading risk factors for severe COVID is obesity. And we know that 40+% of the US population is obese. People don't view that as a medical condition, even though it may be. And even things as simple as high blood pressure, which they may be taking medications for, may increase their risk. And the obesity in particular, that's a huge risk factor in patients under 65 for requiring hospitalization and dying from COVID-19. I think this may have been cued at even younger, like kids. And I think what if you look at what's been going on throughout the entire period of time since kids started going back to school, rates of infection in kids have been going up significantly. Rate of hospitalizations in kids have gone up as well. And I think we thought they were safe in part because they were staying home and not getting exposures. But I think we've seen that kids unfortunately can get very sick, can require hospitalization, and sadly can die from these infections, and why it's ever so important to get kids vaccinated as soon as we can. Unfortunately, currently, children 5 and under are not able to get vaccinated. But again, for those older, should really get vaccinated and boosted when the time comes.
So, and I want to add something here. This has been the subject of significant research, especially for the pre-vaccine era. There were some papers published in very high impact journal Science that were showing that in some people who didn't do well compared to other ones who didn't have worse characteristics, it had to do with the interference system, with some inherent things of their immune system. Without being immunocompromised. But all this is purely academic, is research, and it really doesn't apply anymore because right now we have vaccines and we know that people who get vaccinated are protected much, much more than other ones. So there are some theoretical reasons for some differences beyond the obesity and blood pressure and all that stuff. But again, when you get the vaccine and the booster, all these things go away and it makes a big difference in protecting. So.
Okay, so to wrap up, as I see people are dropping off a bit.
There is one question I see here that I think I wanted to touch about. Someone is referring to her dad who had COPD and was vaxxed and boosted and then got COVID with mild symptoms, but ended up in the emergency room on day 10. And would you recommend to give a monoclonal antibody? I was looking at that, and that's an interesting question. I'm going to let Mike get in, but I wanted to make the point that monoclonal antibody, the earlier you give them, usually the first 5 days are the most important. So when you give it on day 10, that's right at the border of nuts. And I don't know, I was wondering what Mike thinks of that. So.
Yeah, again, it would all come down to timing because the EUA is quite clear. After day 10, you can't give these.
Right, so that's right at the edge of day 10. So
and if he's in the ER, currently the ER is not giving the monoclonal antibodies. So I think he's probably too sick and probably will end up getting admitted, may get a couple of days of remdesivir because that's been shown to reduce the risk of severe disease, and we'll get other things. What's probably leading him to go to the emergency room, which is what we're seeing more with Omicron, is it's probably exacerbated his COPD, and it's really his COPD flare that needs to be managed more so than the COVID.
Right.
Okay, so I was going to say as a last question, maybe look into that crystal ball. When is all this going to be over? When is our life going to start to look more like 2019?
I'm not going to take that one. I'm going to let Mike go for that.
So I think this is an area where we we need to be realistic. Everyone wants the pandemic to be over. They wanted it to be over in May. They wanted it to be over in November. The virus has a mind of its own. New variants emerge. New variants will continue to emerge over time. We have more and more tools, and hopefully we'll get more and more people protected with immunity through infection and vaccination. I point to the 1918 pandemic. The 1918 pandemic needed 11 years before it settled into kind of the standard kind of epidemic flu type seasons that we were seeing. So it may be a long while before we get back to 2019. And to be honest, we may never go completely back to that. We may still see a lot of people wearing masks, a lot of people being extra careful because they've recognized that the illness that they have can be transmitted to other people. I think the biggest thing that people want, the ability to plan and schedule and go on trips, should become much more stable in the coming months. Looking in the short term, as I showed in the data, it looks like we've started to plateau our cases. And so hopefully, like they have seen in London, this comes up very quickly, and hopefully we will come down pretty quickly as well. So hopefully this wave will be reduced pretty significantly in the next couple of weeks. But what the true future holds, I don't think anyone knows.
I want to add something here. And, there was, by the way, today, there was some data from Washington that is a little bit ahead of Chicago. And it looked like it had started coming down in Washington. And hopefully we will follow, that's the timing. But no matter how long it takes, we are in a very different scenario now than we were in the past. Science has really advanced a lot, and you can protect yourself. We have vaccines right now that have saved many, many lives. We have great masks. So no matter what happens, I think we will have much better protection. And one important thing to keep in mind is that these mRNA vaccines right now, which is a big advancement in science, and at the end, is not only going to help us deal with the pandemic going forward, but may impact other diseases as well. So I think we have to try to stay optimistic no matter how long it takes, and do our best to protect ourselves and others.
Thank you. That's a perfect way to wrap it up. And again, we did the best we could with all the questions. There are many more questions than we had time for. We will look to do this again so we can get to even more of you. If you have very specific questions that are related to your condition, please reach out to healthcare providers so you're not waiting for us, as it is difficult to answer specifics without all the information. But thank you all so much. We will post this. All of you registered will receive a link, and we look forward to seeing you soon. Until then, stay safe and be well. Thank you.
Well, and thanks, Alex, because you actually had the hardest job figuring out the questions and asking. Thank you for that.
Bye.
Thank you. Bye-bye.